If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further. Today we have Anna Haghgooie from Vouchercis. Anna, thanks for doing this. Really appreciate it.
Thanks for having me, Vic.
Anna, we've known each other for a while and invested together on a couple of different things. But not everyone may know you in the audience. So maybe let's start off and go through a little of your professional background. You started at Sandbox and Blue Ventures and then came to Vouchercis. But give your background. Where did you come from? What are you up to?
Yeah, so I started my investing career, as you said, at Sandbox Industries, where I helped build the Blue Venture Fund, which was an investing platform in partnership with the Blue Cross Blue Shield plans across the country. In my time there, we raised about $1 billion, invested in probably over 50 companies, but with a focus on access, quality, cost, infrastructure to just try to help the healthcare system work better. One of our deals back then was a company called Change Healthcare, which was in the cost transparency space where we first got a chance to meet probably well over 10 years ago now.
Yeah, that's right. And Blue Venture, let's just touch on that for a minute. You brought together, maybe not all of them, but a significant portion of all the Blue Cross Blue Shield plans across the country into one group to find and then invest in innovation. That must have been quite an endeavor, pulling together all the different Blue plans.
Well, it was a lot of people helped get it done. So we had a strong partnership with the Blue Cross Blue Shield Association from the beginning. And then I would say the early Blue plans that leaned in, that really felt like they had to have a finger on the pulse of what was happening in the private markets, really helped drive, I'd say, a little bit of fear of missing out from the plans that hadn't participated in the early days. So yeah, we started with 11 plans, and when I left, we had 33 of the 36 plans participating in the funds, and there was definitely a lot of coordination and conversations that it took to sort of keep that group of folks aligned. But it became a special place where I think Blue plan executives could come together to really talk about innovation, and that often is not, unfortunately, where people get to focus their time when they're running large multi-billion-dollar organizations.
And I mean, I was from the outside, but what I saw is kind of a learning and best practices sharing amongst the plans through the lens of looking at high growth, innovative companies and how it might change their business. A little bit of fear of missing out is probably healthy. Too much might be too much, but the Blues could stand with a little bit of leaning into innovation, I think. So,
yeah.
And then let's talk about Vouchercis. So maybe describe your role there. You're managing director, I think, is your title. But Vouchercis is a pretty interesting investment platform itself. Maybe let's talk about the investment thesis there, how you think about what you're investing in.
Yeah. So in 2021, Welsh, Carson, Anderson and Stowe, which is a long-standing 40-plus-year-old private equity fund that's focused on healthcare and technology throughout its history.
One of the longest and most established, I'd say.
Yeah. And they wanted to deploy more capital against the trend of value-based care. So it was, 2021, the heyday, I'd say, of a lot of those value models, getting public, trading well. And Welsh really had written, in many ways, at least from my perspective, some of the playbooks on how to think about value-based care in this era of Medicare Advantage and managed Medicaid. And yet had not been able to participate because these companies tended to be more venture stage, more growth stage, didn't need the size check that Welsh typically was writing. And so formed this thesis around how to deploy more capital into value-based care by creating a platform inside Welsh to do those deals. And so,
just before you jump into that, what is the standard kind of right down the middle size of a deal for Big Welsh?
3 to 500 million is the type of equity check that they're looking to.
So for the value-based care, especially, there aren't that many platforms of that scale, or at least then there weren't. Maybe there's becoming more. I think they had pretty big success with NaviHealth, where they leaned in and kind of started at a much smaller level. I think it was 50 million. It might have been something slightly different, and had a lot of success with that. But they can't do that too often, just because the amount of capital they're trying to deploy, sort of.
Yep. No, you hit the nail on the head. I think, they had several successes over their history in smaller, more startup-y or de novo type efforts with member health in the Part D space, with NABA Health, where I got to be a co-investor from the Blue Venture Fund, and even Innovage in the PACE space, where they were real pioneers and had a very innovative perspective on where an opportunity existed in the market. But they were all, I would say, subscale checks for the typical deal. And so that really was the opportunity, is to, instead of sort of doing one of those every other fund, like how do we build a platform that can execute on those market opportunities?
Yeah. And then on the website, on the Vouchercis website, you have the Vouchercis 3 beliefs, which I thought was a really interesting way to frame things. So maybe talk about those beliefs and how they came about and how they shape where you look to invest.
Yeah, I'd say that the sort of tenor of the beliefs is that the fee-for-service system isn't really serving many people well. And that's kind of the core foundational belief that drives the opportunity set that we're interested in. And so broadly, we think about next-gen healthcare as models that are accessible, get you to a clinical endpoint in a transparent and easy way, and or hold hands on the stuff that actually matters to people as they're navigating more complex healthcare needs. And so we see value-based care as a contracting structure that can be really helpful in unlocking the ability to do things differently than just what's done today, which is this encounter-based transactional system. But we also see opportunities for technology and other like access models to drive transformation. So while we're big believers in sort of the true value-based care contract as a way to unlock the dollars to do things differently than status quo, it's not the only way to drive next-gen healthcare.
So is it right, just to rephrase, make sure I'm following, that the value-based care contracting or reimbursement method is a piece, it's an important piece to align incentives, but it may not be sufficient? You might have to add other things, add other services, or bring technology to bear. What I liked about the beliefs is they really kind of frame, so today's health system profoundly underperforms for patients, providers, and payers. So really it's underperforming sort of for everyone. Re-engineering the way healthcare is assessed, delivered, and experienced and paid for is a belief that Vouchercis has. So, we have to rethink or re-engineer the whole system. And you have a responsibility, Vouchercis has a responsibility to invest in or create vision organizations driving change. Pretty ambitious beliefs or large goals to attack.
Yeah, I think that's right. I think we the reality is, having now invested for over 15 years in the market, while there have been amazing companies that have come and scaled, and the ability to really transform what it feels like to get care in America has been slower than, quite frankly, it should have been. And so to us, I think it's this idea that if we're going to do the brain damage of structuring a different type of contract, let's also make the investment in how we're going to show up for patients differently. Let's actually deliver on social needs and like the human side of healthcare. And so we love to partner with entrepreneurs and companies that are sort of in it for creating long-term sustainable value as they tackle these different sort of opportunities or areas of dysfunction in healthcare. So I would say this is a little bit our beliefs, but more importantly, we want to work with entrepreneurs that are very serious and understand how hard it is, but are committed to making true change.
Is it right? It's almost like a signaling tactic, right? You're putting out these beliefs, and management teams that are excited about that maybe are attracted, and then hopefully you see the really big vision, well built out teams that are trying to do something large and impactful.
You got it. Yep. And I think there's a level of seriousness when you want to build your business that way, to investing in the data infrastructure, the med-econ teams, the actuarial models. Like, there's a foundation of investment that has to happen to do this work well. And so I think that's also a big part of what we're looking for, is sort of companies that understand that and are making or have made those investments. The flip side of that then is that these companies are payer ready. So having grown up, with Blues plans and payer partners, they need a payer ready entity to be able to do some of these big swings with. And so, in some ways, you've got to have that level of sophistication to be able to credibly contract and do bigger things with payer partners.
Yeah, so let me dive into that for a bit. Like, I was talking to a guy yesterday who is a kind of a technologist, and he's frustrated with the pace of change. You sort of said that the pace of change in the last 15 years there's been some great companies, but it also has been slow for the patients, for the providers, and for payers, or for us as taxpayers. It's been slower than any of us want. And I kind of think that in healthcare, if you're going to drive change, you have to be aware that it is a big system. People's life is at stake, and it needs to be serious. You have to have enough capabilities, enough capacity, enough strength to abide by the regulations and really ensure patient care as you're approaching these new models. Is that part of sort of how Vouchercis approaches things?
Yeah, I think so. I mean, I think we all want it to be faster. I think it can be fast. Like, I think during COVID, we saw this industry move faster. So I think when there's a need to do so, the market can move. But otherwise, like, inertia, regulation locks in the status quo. Those that have market power have no incentive to change, and market power means distribution, capital. So, like, I think it's an industry that's quite sticky, and so you do need external forces in some ways to drive the investment dollars coming in, and people taking big swings. And I think over my investing career, and you've seen it too, the passage of the HITECH Act and actually getting physicians onto digital systems, the passage of the ACA, and this idea that there might be this consumer segment, at least when it comes to plan selection, expansion of Medicare, Medicaid, the growth of Medicare Advantage, the sort of influx of the CMMI models. Like, I think all of these moves sort of drive opportunity for entrepreneurs to sort of execute and show that there's a better way. And once you do that and show there's either a cost advantage and patients are moving, with their feet and choosing to consume care in different ways, then I think the rest of the market starts to react.
And let's double click on your concept of payer readiness. Is that part of what's needed to drive change, where you might bring a new way to deliver care, a new provider design, but your experience at Sandbox and Blue Ventures, and then now at Vouchercis, you know sort of what the payers need, how to plug into their systems so that it can scale, so that you can actually have a meaningful impact on a large percentage of the population.
Yeah. Yeah. I mean,
what's the most common thing that a management team wouldn't realize that they need to do in order to be payer ready?
I don't know that it's fair to say a management team wouldn't realize, but certainly just like data exchange and getting through a security questionnaire is like the first long pole in the tent, and like understanding that and being ready to actually have a place to land data and get through those security audits. Then you get into like pricing and contracting, and there's a level of nuance and complexity to be able to structure a contract that's good for you as the startup, but also is solving the payer's needs. And so I would say, in my experience, I've been part of companies where we pushed and signed contracts ahead of we just signed what the payer was asking for to get a contract signed. And there are others that have slowed it down for what ends up being probably another 6 months to try to get the contract where it's going to be a good long-term contract. The latter is so painful, but almost always the right decision to a point. At some point, you've got to have a customer to get going. And then I would say, like, just the credibility to step into some of these risk models or some of these transformative models. So like, do you have the balance sheet? Do you have the team in place? Again, I think Medicon and data are like just foundational to be able to understand everything from what's happening in the existing population to being able to price a contract, to being able to understand how you're performing against it.
Yeah, and do you think? Well, I think that it's one of the things that Vouchercis brings is for a management team. You can introduce you yourself or other folks at Vouchercis or your operating partners or network have gone through this many times before, and so you can sort of help them think about what questions are going to be asked and really build the credibility before you give that first impression to the payer, because it's a credibility momentum thing. Like if you show up with all the answers that the questions they want right away, you start to build credibility. And if you are not ready, then you're on this 24-month, march of lots of due diligence because they're worried about messing up their systems.
Yeah. Yep. Vouchercis was started in partnership. My two other partners, Carrie Whitty and Tracy Ball, they've spent their careers building and running large scale operations, including many payers and payer functions. So it absolutely helps, that we've got folks that have been in both the buyer seat and the operator seat to be able to help our companies be ready.
Okay, and then what's the relationship with Wells right now? So you trade deals back and forth based on the size. So you might see a really big opportunity and pass it to them. How is the back and forth with Wells Carson?
Yeah, I mean, I think the way that we approach the market is, we're sort of in some ways one team where like we can talk to an entrepreneur about a minority earlier stage transaction all the way through, if they're trying to do a majority deal. And in the healthcare markets, with the way that, in particular on the payer side and these value-based care side, like the companies run the gamut between sort of stage and capital need all the way through. And so that's really it's a very collaborative approach between the two teams, and really play to each other's strengths. So, we see a lot because given the side of the market that we're in, and we're all talking to the same payers. And so there's a lot of coordination between us all.
Great. Okay. So we have a decent number of management team folks in the audience, health system executives, physician, payer executives. What are you thinking about as for 2025? What are some themes, and what are you looking at as an emerging space that could be pretty exciting?
Yeah. So I think one of the spots, just given the headwinds in Medicare Advantage, I'd say a lot of investors are shifting to look at what I'll say like more specialized populations. So whether that's the dual eligible populations, the populations where there's integrated managed long-term services and supports with clinical models. So those are both kind of end markets that I think are getting a lot more attention from investors. than they have the last several years. And we think there's, again, a lot of opportunity to sort of reallocate how those dollars get spent, to drive value across the
So
value chain.
you might segment off a particular population base, dual eligible or special needs or something like that. I've seen a lot of disease state focus as well. Like maybe you pick cardiac, or you pick some other disease state where you kind of focus on that and try to get some critical mass. Is that something you're looking at?
Yeah, so we've definitely done a bunch of the specialty models within our portfolio, whether it's the substance use disorder population with WasteSpring or
I think actually the two I have are similar to that.
Right? Yeah, Taylor Care in the musculoskeletal space, and I think the truth is, like, there are probably still more to do where there's a big enough spend and a need for a specialized contract between the payer and that specialty area. When you start to get into stuff like cardiac and pulmonary, the need is, I would say, a little bit more like, how do you think about the care and the actual like provider services associated, more than maybe a risk deal. And so thinking about like pulmonary rehab as an interesting underutilized service, like is there a different way to provide that, either through some virtual or hybrid model, that can actually increase the utilization of a clinical service. So I think those are all really interesting, and spots where we're spending time.
With some of those, you might have to be integrated or have partners in acute care settings, whether they're part of the core business or more likely they're sort of partners, or you refer back and forth. Is that right?
Yep. Yeah, the like health system service line extension model, I think, is another interesting thread, which is, there are things that aren't going to necessarily be core to a health system's business, but they do have the eyeballs, the brand, the reputation in a market, and can open up some of these more virtually oriented service lines to their community and their patient populations. And while they're not necessarily big money makers for the health system, it helps keep people in their community sort of connected to them and getting the care they need.
Yeah. So like your teams maybe could get more scale and run the operations efficiently, where you could make decent gross margins, net margins, but it wouldn't be that attractive to a single health systems. And so there's a natural partnership there.
There you go. Yep.
Yeah. Okay. I know we're recording this on the 23rd. HLTH Health in Vegas is just now finishing today, I think is the last day. This will air in a week or so. So you're in the middle of it. I don't know if you had a chance to have any takeaways, but how was the event? I skipped it this year because I can only take so much of HLTH. And this year I decided to skip it. But how was it?
Yeah, no, it was a good couple of days. I had a good set of meetings, met with a lot of entrepreneurs, a lot of co-investors. So it was well attended. And I would say generally a fairly optimistic air, as much as there's a lot of headwinds in healthcare. There have been some big wins this year. I think people are expecting the IPO markets to open back up next year. And so I'd say, generally speaking, like a lot of energy around where we're headed.
Yeah. And the election, we're going to have the election in a couple of weeks. At least my view is I want the election to be over. And then, I think I can work with any kind of administration, but it'll be good to have the clarity of, okay, this administration is now in charge, at least for a couple of years, and then we can work with that. What was the sense out there? Are people hoping that one side or the other will be better for healthcare, or is there a 50-50 split? What was the sense?
Yeah, well, I'd say the only people that are hoping it to be over more than you are anyone who lives in a swing state, given
yes, that's right. That's right.
Amount of money that's
pretty much locked in Republican, but yeah, I think the swing states have got to be peppered with ads all the time.
Yeah, you know what? Honestly, it's relevant in a couple of pretty small pockets in sort of my world and deal flow, like what's going to happen with ACA subsidies. Medicare Advantage headwinds. Like there's a few of these buckets that like may fall one way or the other depending on who's elected. But I think when we talk about getting more value for the dollars we spend in healthcare, like that's a bipartisan goal. And quite frankly, well, things might be called differently, or there's different emphasis on different parts of the program depending on who's running the show. The general fundamental ways to get there, I think, are pretty well. There's good alignment, I'd say, between both parties.
That's how I view it too. Like sort of delivering more effective care where the physicians and nurses and caregivers, are fulfilled in their job and earn a living wage, and getting better outcomes for lower cost. That sort of works in either administration. You might have different framing. It might be slightly different reimbursement. But I think VCs can work either way, really.
Yeah.
Okay. I want to highlight a couple of your portfolio companies just to sort of showcase the type of deals that you do. I had focused on Wayspring just because I know Carter here. And so maybe describe Wayspring, what they're doing, and talk about how that sort of represents Vouchercis, or maybe there are some exceptions there that are not exactly sort of a Vouchercis core deal.
Yeah. So Wayspring is a Nashville-based company led by Carter Payne and a really wonderful management team. And they partner with managed Medicaid plans to essentially carve out the risk associated with the substance use disorder diagnosed patient population. So this is one of these value-based models that's 365-day risk on a belly button level. So like who are the people that fit this cohort based on a diagnosis? And then what Wayspring does is essentially takes that attributed risk and figures out who they need to engage and how they need to work with them in order to get a different utilization pattern, quite frankly. And so the company works really successfully to drive engagement of the patient cohort that appears to be struggling the most based on the data that they're getting from their health plan partners. They show up in the community and work with community-based organizations to essentially put in a system of care for these members. And care is not actually what we think of as traditional healthcare. It starts with social needs. It starts with how do we create stability in someone's life? Do they need a hot meal? Do they need a warm bed? What are the things that they need in order to, again, start to then have a conversation about what recovery might look like? And I'd say in our current system, that patient is showing up to the emergency department to get a hot meal or a warm bed, or they're cycling through inpatient rehab and then sent back out into the the community without a hot meal or a warm bed. And so really what Wayspring is doing is starting with those foundational layers and then working to, again, get this person tied into a system of care that addresses substance use dependence, mental health, and then ultimately physical health. And so the stories are incredible as far as, the lives that have been changed through the work that the Wayspring team is doing. But they also have proven that the model, while it costs a lot to do that, ultimately saves money. And so what I love about it is you're repurposing dollars that are being spent right now, in a health system or in an inpatient rehab, and they're not dollars that are
they're not utilized very well. We're spending a lot of dollars, but they're not designed for this population with this goal. It's sort of an ED is really good at dealing with trauma, maybe not good at complex social, behavioral health, substance abuse issues.
Got it. You got it.
I think it's a really interesting example of where this value-based care contracting structure allows Carter and his whole team to really think about the patient and caring for the patient in a very different way, because they have that capitated risk. And then they can choose how to spend the money. It might be that they partner with a local nonprofit community partner to deliver meals or deliver, I don't know, one place to sleep, or other social services, teach someone how to find a job, all those kind of social services that really are building blocks to allowing the person to have a productive, rewarding life. And that from that foundation, you can then start working on the recovery and substance disorder.
You got it.
Yeah.
Yep.
And then, if the team is successful, by definition, they earn money relative to the lower spend, but they can only do that by helping the people recover, helping the people live more productive, less expensive lives.
You got it.
Yeah.
Yep. Yeah. And so I think that, I mean, it's a good showcase, I'd say, of like what Vouchercis, was set up to do, which is like there's a lot of complexity in getting to that end state. And so partnering again with management teams like Carter that are very serious about changing the status quo very substantively for the patients that they're serving is.
Talk to me about what's the scale of Wayspring? How many states, or what's the give us a perspective of how big it is.
Yeah, I think they're in 7 states now, and in many of those states have multiple of the managed care plans as partners. So they're able to essentially bring this level of service into the communities and serve Medicaid patients across multiple plans. They've grown exceptionally well over the last 3 years, and really starting to prove a track record on savings, which is what we're all really excited about.
Yeah, that was my next question: is what's the time horizon that you think is fair to judge a company like Wayspring?
Yeah, each of our value-based care companies are different, and it just depends on like what the risk is that they're contracting around and how sort of long it takes to generate an ROI. In the substance use disorder population, you can see the savings within the 12-month sort of window. So they're in-year savings. And we've gotten through 2 years of reconciliation with our most mature clients. And what we look for is sort of escalating savings year over year. So as you begin to build relationships and drive higher engagement, get your system of care humming in a given community, are those savings, accumulating year over year at a cohort level. And so,
but hopefully the team and the algorithms and the community partners and how it all fits together, you're getting better, smarter, more efficient each quarter. And so you start to see escalating savings through that lens.
Right.
Yeah. Okay. And then talk to me about Tuesday Health. I don't know Tuesday Health as well, but I'm really interested in that space. So maybe describe what it is and how it is different and in some ways the same as the same kind of model.
Yeah. So Tuesday Health is our company that's focused on end-of-life care. And essentially the thesis that led us to Tuesday is that despite all of the complex care management companies and risk-based primary care, nobody was really excelling at identifying the right time to drive end-of-life conversations and services. And what we realized is that one of the reasons why that was so hard is because you really have a hard time teasing out from claims data and utilization data when that right time is. And because the drivers typically tend to be certainly utilization and diagnosis data and those things, but also coupled with someone's functional status, their symptom burden, how are they experiencing the symptoms associated with their diseases, and then what is the caregiver dynamics available to them in their home and their community. And it's those things that actually are the drivers of how somebody is going to experience those last 12 to 18 months of life. That coupled with the fact that hospice as a benefit is a really wonderful benefit, but it is expensive. And there's this Goldilocks paradigm within hospice, which is patients are either getting on hospice too soon, a nursing home patient with dementia that probably does need a little bit extra than what they're getting today, but probably doesn't need the full hospice benefit to folks that are getting on, 3 days before they're passing, and that's just not enough time for hospice to deliver any value or services to that family. And so this like Goldilocks problem of how do you get it just right, where you're bringing somebody into that set of services at the right time in their journey. And again, one of the reasons why that's so hard is because nobody's really focused on that in the existing system. And
yeah,
so
and it strikes me it takes a lot of talking to the patient and their caregivers and listening, which is hard to do at scale. You can't just sort of run a risk stratification and say, okay, these people are the ones that need it. It's more nuanced than that, right?
That's right. That's right. So we partnered with Mass General Brigham, who had a really talented palliative care research program in the beginnings of a tool, and so they're investors in the business as well as contributed some assets. And then CareSource, which is a managed Medicaid and dual eligible plan based in Ohio, who also was really interested in this space. And we brought in a number of executives who are also very passionate about this space. I think the one thing is we went out and sort of put this together is, folks that are now sort of in leadership positions across the industry, given their age. Many of them have dealt with end of life with their parents, and so it really hits close to home. No matter how well resourced you are, it's not great. There's not a great model of care and support in this country. And similar to birth, you're only going to do it a handful of times in your life. How are you supposed to have the experience for sort of how to work through prenatal process? Well, similarly with death, hopefully will only have to navigate a death and dying experience a handful of times in life. And so there really is, I think, a need for a partner that can help sort of navigate and prepare families for what that's going to be like.
Yeah, and it's so intertwined between like the emotional pain with the patient who is scared and their loved ones, combined with the confusion of, well, these options are possible treatments, but they're going to be inpatient, and there'll be forget the money, there'll be lots of side effects and tubes, and it'd be difficult for my parent, but maybe it could really help and could buy another several years. And so getting an honest and kind of unbiased partner to help with that, I think could be really valuable. But there's a lot of trust that has to be established in order to sort of get that buy-in.
Yep, trust. And then I think some of it, there's even just like you don't know what to expect. And so, the process of watching someone struggle through end of life it is painful. And so the default position is to call the healthcare system to come in and try to help. And the healthcare system is not set up to sort of understand a more palliative approach, which is, all around whole person care, goals of care. It doesn't just mean hospice. It's actually much more about sort of managing symptoms so that people can achieve goals in life. And so it's just a different orientation, and we're pretty excited. The company is young; it's just a year old, but is working with patients and for better or worse in this industry, there's just so much low hanging fruit. And this is a category of care where, people are very interested in having somebody come in and help them with this process. And in return, I think we're starting to see the beginning of a model that's working really well.
Yeah. I mean, I would say that the traditional fee-for-service system, which is still, it's probably 90% of the revenue running through the system, or maybe you have exact stats, but it's a significant part. That system is it's optimized for like acute interventions. Let's fix this thing and then send you home. And as you get towards the end of life, that's not necessarily what's needed. You have lots of health conditions and they're beginning to add up on each other. And it's about sort of managing this for the best quality of life, which is just a different mindset or different approach.
Yep. Yeah. And the research suggests that palliative care actually helps people live longer, and have less trauma through the dying process for those that have survived. So I think there's really no downside. And so the real question is like, how do you take what has been an under reimbursed service line in healthcare and figure out a sustainable model for figuring out when to spend those extra dollars on the service line in a comprehensive way. And so that's really what
Right. We all know that the last 12 months of life are really expensive, but it's difficult to know when that 12 months starts, right? Because obviously you don't know when the person's going to die. And so that, how is Tuesday Health, what is the contracting set up for you? Is it again, a capitated rate, or is it a different format?
Yeah, so Tuesday's going to market pretty flexibly just because there's a lot of different pools of populations that can benefit from the services. But ultimately, one of the tenets that we believe in is we want to be accountable for engagement. So we want to take what is an attributed population based on the data that we do have. And we want to engage that population to then understand sort of where they are in that process. And so I think that's the other piece is, seeing prior models of like one size fits all, you're either in or out, similar to hospice. It's one size fits all, you're either in or out. This is much more of a gradation of what does that patient need at this point in their journey, and how do we start to support the family and the patient in a way that gives us the trust to help them all the way through. So we want to be at risk for engagement. We want to work with folks that currently hold the risk on that patient population, whether it's risk-based primary care or a payer. And we're going to work with those longitudinal care providers to essentially integrate into that patient and that family's care. And so, we want to be at risk for outcomes because we think there's really meaningful outcomes to deliver, but we're fairly flexible.
Yeah. And I know you said that one of the things Tuesday is exploring or sort of challenging is the time when this topic should be brought up. It strikes me we need to start talking about much earlier. Is that what they've found? Or when are they starting to engage?
Yeah, so the attribution model is trying to catch folks within their last 24 months of life, so that you have some time to actually engage and build a relationship and start the conversation. In that patient cohort, there's a concept called prognostic awareness, which is essentially, does the person even know that they're likely headed towards a somewhat shorter window?
So for instance, 78-year-old man falls and breaks his hip. I think he now is in the 2 years left to live, depending, because there are lots of other factors, but he may not be aware of that. And so how do you bring up that topic and talk through what's going to happen over the next few months or years? It's emotionally charged, at least.
Yep. Emotionally charged. And I would say this is where, like, I don't know if you've spent any time with palliative care clinicians, the nurses and physicians that do this work, they are very skilled at sort of having these conversations.
I think they feel like saints to me. Like, I don't know how they do the work they do, but it's incredible.
Yeah. And I think that it's been an underappreciated, clinical cohort in the current reimbursement system.
Right.
And so, but it's also part of why this doesn't happen, right? Because I think most other clinicians and stakeholders in the healthcare community are not comfortable having those conversations.
Yeah, they weren't really taught it very extensively in medical school, if at all. Yeah. And so they don't want to say the wrong thing, and they just end up not talking about it that much. Yeah. But it's great to have a partner in Tuesday Health or an organization that they can pull in. Either you can help them better learn about it, or they can hand the patient off.
Yeah. And it's not just the conversations, like it's also like, what's the system of care to help somebody as they're managing functional decline and increasing symptom burden, and so it's all of the psychosocial and emotional parts, but also a true system of care as well.
Yeah. Excellent. Well, it strikes me that Vouchercis is really kind of leaning directly into kind of the core of figuring out how to fix this profoundly underperforming system that we all live with now. So I really appreciate the work you're doing. Are there other topics that we should touch on or themes that we didn't cover?
No, and I just say it's actually the entrepreneurs that are doing the hard work, the leaning in.
Yes.
But we do love to partner with those folks and help out the way that we can as capital partners and board members.
Yes. Yeah. Okay, Anna, thanks for your time. How should people learn more about you or Vouchercis, or maybe I'll put links in the show notes for your website, but there are other things that you want to point to?
Yeah, no, I think that's a good spot. Reach out if you've got ideas, and appreciate the opportunity to share a bit about what we're up to.
Yeah, great. Thanks, Anna. Appreciate it.
Thanks, Vic.